So global rates of obesity and type 2 diabetes are increasing globally, concomitant with the rising prevalence of sleep deprivation and sleep disorders. We know both sleep habits and sleep disorders are highly prevalent among adults with diabetes in general. However, interventional studies addressing sleep abnormalities in populations with or at high risk of diabetes are scarce. So although common sleep abnormalities are associated with risk of incidence, usually type 2 diabetes and worse prognosis in those with established disease, there are few randomized trials evaluating the impact of sleep-focused interventions on diabetes and make it difficult to determine whether the relationship is causal or not. So understanding the links between sleep and diabetes might offer an opportunity to develop better prevention and treatment strategies for these epidemics. And with this in mind, we developed this pilot study. So again, this is data from a larger epidemiologic pilot study, the BED Lab, and it is an observational cross-sectional study where we collected a convenience sample of patients over 18 years old who attended to our health unit, Coimbra Sul, which is located in the center of Portugal, in a peri-urban area between April and August of 2022. So we collected a sample of 131 individuals, 20 of which had diabetes. This is a little mistake. So 20 reported to have diabetes or pre-diabetes. And from exclusion criteria, we had younger than 18, illiteracy, absence of total autonomy, and refusal to participate in the study. So all participants declared their verbal and written consent after personalized contact. The participants answered a self-completion structured questionnaire with optimal anonymously while waiting to enter the medical appointment or after it, and questionnaires were available both in paper or digital formats. So this is the structure of our study. So basically in the beginning, we had a section of sociodemographic questionnaire. And then we had the part of global sleep evaluation with the Pittsburgh questionnaire, which is a Pittsburgh that is highly usually used in this kind of studies. It is very, very much used and well known in the area. And then the second part of the questionnaire, it was related to sexual function evaluation, which we will not address in the present study, but we already did in the presentation before. So descriptive and inferential statistics were prepared using Excel and SPSS, and a descriptive analysis of the sample was carried out according to gender and in global. So here we are, the social demographic characteristics. We had a total of 20 patients that reported diabetes or type 2 diabetes, 10 women and 9 women and 11 males. So, and the patients had between 18 and 70. The majority of patients did not have a superior level of education. Most of them were married or had a non-marital partnership. Most of them were retired and lived in an urban area. From the diabetic population, so we know that the majority had established diabetes mellitus, with 1 being gestational diabetes, and 23.8% reported to have prediabetes. So from these patients, almost half were medicated with metformin, 90% with inhibitors of SGLT2, and 99.5% of insulin. The 2 comorbidities with higher prevalence were of diabetes were hypertension and also mental disorders. So the results we have by a specialized sleeping professional, and 4% of the patients chronically resort to hypnotics, and from these 75% use benzodiazepines daily. Overall, the average hours of sleep per night were 7.23. And here we have a sum up of the Pittsburgh score. So we can see that, so in the Pittsburgh score, is considered to have a score over 5. It is considered to represent, in total, 45% have a Pittsburgh score that is suggested to show sleep disorder. These are not irrelevant numbers. So we can see this is a problem that needs to be addressed more often in our consultations with our patients. So we also see there are 20% are already using a total of sleep agents, 20% of the total, and 50% use benzodiazepines. This also needs to be addressed. I think this raised the awareness of how we need to address sleep disorders, and how also family doctors need to learn how to manage those sleep disorders in order to prevent iatrogeny, especially linked to benzodiazepines or other kind of therapeutic that can damage the sleep condition in the long run. So further conclusion of the study might put into evidence the existing correlation between diabetes and the final Pittsburgh score, because obviously this is a pilot study and we have a limited sample, as well as specific sleeping domains. So we have some strengths in this study. We can see there is anonymity and lack of confrontational stress, the usage of a validated questionnaire, and the usage of a subpopulation of specific interest, and also as limitations, obviously the simple size, since we are talking about a pilot study, the choice of a convenience sample, and the lack data that could possibly relate the severity of the symptoms with possible anthropometric and biometrical parameters. These strengths and limitations had already been discussed in the previous presentation, so I will not repeat myself, but we cannot say they are not important. So in conclusion, the study brings evidence of a high prevalence of sleep disturbances among stable patients with diabetes and prediabetes, as well as the lower underrated diagnosis in this field. Further continuation of the study might put into evidence the existing correlation between diabetes and the final Pittsburgh score, and further investigation might allow to plan interventions on a practical environment for diabetic patients in the near future in order to improve the quality of life, as well as their cardiovascular risk, which is been proven to be linked to the sleep quality. And this is all I had for you. I hope you enjoyed my presentation. We cannot hear you.
Sorry. Thank you very much, Dr. Rita. That was wonderful.